Hi everyone, this is Dr. Nadia, working as an assistant professor in the Department of Oral and Maxillofacial Surgery in Adiparashakti Dental College and Hospital. Today the topic I'm going to discuss is about the maxillary injection techniques. All oral surgical and dental procedures are often performed in an outpatient setting. So the local anesthesia is the most common method of anesthetizing the patient. The type of procedure performed as well as the location of the procedure determine the technique of anesthesia to be used. So the successful and safe local anesthesia is the foundation of modern clinical dentistry. Only with thorough understanding of the local anesthetic injection techniques and their anatomical basis is must to provide high quality treatment in a pain-free environment. So before we move on to the injection techniques, let's have a quick recap of the anatomy of the maxillary division of trigeminal nerve, which is the largest of all the cranial nerve. The sensory cell borders of the trigeminal nerve forms a trigeminal ganglion, or also called as semilunar ganglion or Gasserian ganglion, situated in the Meckel's cavity in the petrous portion of the temporal bone, where it gives off three large branches. One is the ophthalmic division, the second division is the maxillary, and the third one is the mandibular division. So the maxillary division is purely sensory in nature. Again, it gives off four branches, that is the branches situated within the cranium, which gives off middle meningeal nerve, supplies the dura mater, branches in the pterygopalatine fossa, and branches in the inferior orbital fissure, and branches on the face. So within the cranium, I said it gives off middle meningeal nerve, which supplies the dura mater. So it leaves the cranium through the foramen rotundum and enters onto the face below and behind the space situated behind the orbital cavity, which is called as the pterygopalatine nerve, where it is situated in the pterygopalatine ganglion. Again, it gives off numerous branches. One is the palatal branch, which supplies the soft and hard tissues of the palate. One of the branches is the greater palatine nerve. The orbital branch, which supplies the periosteum of the orbit. The nasal branch, which supplies the mucous membrane of the nasal cavity. And the pharyngeal branch, which supplies the mucous membrane of the pharynx. So again, in the pterygopalatine fossa, it gives off two more branches, that is the zygomatic nerve. Again, it is divided into zygomatico-temporal and zygomatico-facial nerve. The third one is the posterior superior alveolar nerve, which supplies the mucous membrane of the maxillary sinus as well as pulpal anesthesia of the maxillary posterior teeth. So the maxillary nerve travels through the inferior orbital fissure and enters into the orbit, where it is called as the infraorbital nerve, where it gives off two branches, that is the middle superior alveolar nerve, which supplies to the pulpal anesthesia of the premolars as well as the mesobuccal root of the maxillary first molar, and the anterior superior alveolar nerve, which supplies the pulpal anesthesia from the central incisor till to the mesobuccal root of the maxillary first molar. And the infraorbital nerve, which exits on the face through the infraorbital foramen and gives off three terminal branches. One is the inferior palpebral, which supplies to the lower eyelid, superior labial, which supplies to the upper lip, and lateral nasal, which supplies to the lateral wall of the nose. So this is the anatomy of the maxillary division of the trigeminal nerve. So here you can appreciate in the clinical in this picture the course of the infraorbital nerve, and where it gives off the anterior superior and middle superior alveolar nerve. The anterior superior alveolar nerve supplies the soft tissues in and around the maxillary central incisor till to the mesobuccal root of the first molar, and the middle superior again it supplies the premolars and the mesobuccal root of the first molar. The posterior superior alveolar nerve supplies the pulpal anesthesia of the maxillary posterior teeth. So again, the nasopalatine nerve gives soft tissue anesthesia on the palatal aspect for the anterior teeth from this 1-3 region to the 2-3 region. The greater palatine nerve exits through the greater palatine foramen and supplies the hard palates, soft and hard palate, and also the soft tissue anesthesia on the palatal aspect from the first premolar till to the third molar region. So to summarize, the maxillary nerve innervates the skin, that is the middle portion of the face, lower eyelid, side of the nose and upper lip, and the mucous membrane of the nasopharynx, maxillary sinus, soft palate, tonsil, and hard palate. And also the dental structures, that is the maxillary teeth, surrounding periodontium, alveolar bone, and the gingiva. So before move on to the techniques of anesthesia, we should know these three terminologies, that is the local infiltration, field block, and nerve block. So what is infiltration? This is the common usage in dentistry to define an injection in which the local anesthetic solution is deposited at or above the apex of the tooth to be treated. That is, it anesthetizes the circumscribed area of the tooth whenever you want to do the procedure for a single or two teeth. So it anesthetizes the terminal dental plexus. So the technique of anesthesia, you should approach at or above the apex of the tooth to be treated. So the field block is the other term, that is, it's anesthetizing the large terminal nerve so that the anesthetized area is circumscribed to prevent the passage of impulse from tooth to the CNS. That is also, it anesthetizes the terminal nerve branches. In general, the infiltration and the field block is one and the same because it anesthetizes the large terminal nerve branches or dental plexus circumscribed to the particular region. So coming to the nerve block, what is nerve block? The nerve block is deposited close to your main nerve trunk, usually at a distance from the site of operative intervention. For examples, posterior superior, infraorbital, nasopalatine nerve block, and greater palatine nerve block. And the advantages are it produces much larger anesthetic field, and it also gives prolonged duration of anesthesia. So let's have a look of each individual techniques. First and foremost is the supraperiosteal injection. The other common names is local infiltration or paraperiosteal injection. The nerves anesthetized are large terminal branches of the dental plexus. The area anesthetized, the entire region innervated by the large terminal branches of this plexus, that is the pulp and root area of the tooth, buccal periosteum, connective tissue, and mucous membrane. So where it is indicated, it is usually indicated when the pulpal anesthesia of the maxillary teeth, that is the treatment is limited to one or two teeth, and also the soft tissue anesthesia when indicated for surgical procedures in a circumscribed area of the region. The contraindications are infection or acute inflammation in the area of injections, where you can go for a nerve block. And the second contraindication is dense bone covering the apices of the teeth. So the advantage of this supraperiosteal injection is high success rate, greater than 95%, and technically easy injection, and it is very simple to perform and usually entirely atraumatic. The disadvantages are it might require multiple needle insertions. Sorry, it needs multiple needle insertions and the necessity to administer large total volumes of local anesthetics. So coming to the procedure, how to perform the supraperiosteal injection, you can use a 27 gauge short needle. The area and the target area of insertion of the needle and target area are same. That is the apical region of the tooth to be anesthetized. The landmarks are mucobuccal fold, crown of the tooth, and root contour of the tooth. So first, before do with the injection procedure, prepare the injection site. Apply topical antiseptic, that is optional. Apply topical anesthetic for a period of 1 minute. Then you can start giving the procedure. That is how to orient the syringe. The syringe should be held parallel to the long axis of the tooth at the height of the mucobuccal fold. So particular to the teeth wherever we are going to operate or wherever we are going to do the procedure. That is the apical region of the tooth at the mucobuccal fold. You can administer of about 1/3 of the local anesthetic solution is sufficient, of roughly of about 0.6 ml over a period of 20 seconds. So after anesthetizing the injection, withdraw the syringe, recap the needle, wait for a period of 3 to 5 minutes for the anesthesia effect to for the anesthesia effect to achieve. So this is the supraperiosteal injection technique. Next, we move on to the posterior superior alveolar nerve block. The nerve anesthetized are posterior superior and its branches. So the area anesthetized are the pulps of the maxillary third, second, and first molar. With the exception in 72% of cases, the mesiobuccal root of the first molar is not innervated by PSA nerve. In such cases, the innervation is usually from the MSA, that is the middle superior, or from the anterior superior alveolar nerve. So it also anesthetizes the buccal periodontium and bone overlying these teeth. So the indications is when treatment involves 2 or more maxillary molars, and when supraperiosteal injection is contraindicated in case of infection or acute inflammation, and whenever the supraperiosteal injection has proved ineffective. The contraindication is the risk of hemorrhage is too great, as with hemophilic patients and also the patients who are under anticoagulant drugs. In such cases, you can prefer supraperiosteal or periodontal ligament injection. So coming to the technique, a 27 gauge short needle is usually recommended. The area of insertion of the needle is height of the mucobuccal fold above the maxillary second molar, and the target area is posterior, superior, and medial to the posterior border of the maxilla. The landmarks are mucobuccal fold of the maxillary second molar, maxillary tuberosity, and zygomatic process of the maxilla. So the technique is, this is the injection site. So the position of the needle is upward, inward, and backward direction, maintaining a 45-degree angle to the occlusal plane. That is, upward superiorly at a 45-degree angle to the maxillary occlusal plane, and medially towards the midline, maintaining a 45-degree angle to the occlusal plane, and posteriorly, that is, at a backward direction, maintaining a 45-degree angle to the long axis of the second molar. Okay, so the point of insertion of the needle is usually at the mucobuccal fold of the maxillary second molar, and where you can appreciate here. So in this clinical picture, you can appreciate the direction of orientation of the needle. Exactly, the target area is at the mucobuccal fold of the maxillary second molar. You can, while doing this procedure, you have to ask the patient partially close his mouth and move the mandible towards the injection site. This maneuver relieves the tension on the cheek mucosa, and you will get a better accessibility to give the PSA nerve. So you can either use your finger to retract, or you can use an instrument to retract the cheek mucosa to prevent inadvertent needle stick injury. So the advantages of performing a posterior superior alveolar nerve block is atraumatic. It has a high success rate and minimizes the number of injections, and it also minimizes the volume of local anesthetic required. It usually requires 1.8 to 2 ml of solution. The disadvantages are risk of hematoma. This is because at the area of vicinity of the injection site, you will be having a pterygoid plexus of vein, and in case if you inadvertently injected into the pterygoid plexus of veins, or the internal maxillary artery is perforated, there might be of risk of hematoma formation. And the technique is too arbitrary. The infiltration required for mesobuccal root for first molar is usually required if the innervation is not from the PSA nerve. So in such cases, you need to go for an additional supraperiosteal injection, or also called as local infiltration. The complications are, as I said now, hematoma formation, and in some cases, the patient will tell, while giving a PSA nerve block, sometimes the patient will tell the half of the tongue and the lower lip is also get anesthetized. This is usually because lateral to the PSA, your mandibular division of the trigeminal nerve emerges. So if the orientation of the needle is towards too laterally, then there might be of chance of anesthesia of the mandibular division. So next we move on to the middle superior alveolar nerve block technique. The nerve anesthetized are middle superior and its terminal branches. The area anesthetized are the pulse of the maxillary first and second premolars, and in some cases, if the innervation is not from the PSA nerve, then the MSA supplies the mesobuccal root of the first molar. This study was performed by Losher and his associate in a dissection specimen, and he found out that only in 28% of patients, the innervation is from the MSA nerve. And the remaining 78 group of patients, usually the innervation from the anterior superior alveolar nerve. That is, the anterior superior alveolar nerve itself anesthetizes the premolars. Okay, and it also anesthetizes the buccal periodontal tissues and bone over the same teeth. So the technique is, I have to use 27 gauge short needle. The area of insertion is height of the mucobuccal fold above the maxillary second premolar. The target area is same, maxillary bone above the apex of the maxillary second molar. And the landmark is mucobuccal fold. Again, the orientation of the needle is parallel to the long axis of the maxillary second premolar at the height of the mucobuccal fold. So here in this clinical picture, you can appreciate clearly at the height of the mucobuccal fold parallel to the long axis of the maxillary second premolar. So the signs and symptoms, again, the subjective symptoms, the patient will feel the numbness at the injection site, and objective, usually absence of pain during the treatment. Next comes the anterior superior alveolar nerve, which is also called as infraorbital nerve block. The nerve anesthetized are anterior superior, middle superior, infraorbital nerve and its terminal branches, that is the inferior palpebral, lateral nasal, and superior labial. The area anesthetized are pulse of the maxillary central incisor through the canine. In about 72% of patients, the pulse of the maxillary premolars and mesobuccal root of the first molar is also innervated by anterior superior. And the other area anesthetized are buccal periodontium and bone of the same teeth, lower eyelid, lateral aspect of the nose, and upper lip. So how to go about this procedure? The technique is you have to use a 25 or 27 gauge long needle. The area of insertion is height of the mucobuccal fold directly over the first premolar, and the target area is the infraorbital foramen below the infraorbital notch. The landmark is mucobuccal fold, infraorbital notch, and infraorbital foramen. So in this clinical picture, you can appreciate clearly. So when you appreciate the medial aspect of the pupil or the mid-pupillary line, the infraorbital notch, the infraorbital foramen, the mucobuccal fold of the upper first premolar lies in a vertical plane. Okay, so how to do this procedure? You have to palpate the infraorbital notch. Okay, few millimeters below the infraorbital notch, you can appreciate the infraorbital foramen. Okay, you have to this is an this line lies in a vertical plane, that is the infraorbital notch, infraorbital foramen. As I said just now, the maxillary first premolar, all these three exits in a vertical plane. So intraorally, you have to reflect the tissues, make the tissue taut. The needle insertion is at the height of the mucobuccal fold of the maxillary first premolar. The depth of penetration of the needle is of about half of the needle, that is roughly 16 millimeter, but this varies from individual to individual depending upon the location of the foramen. But of an average sized individual, the depth of penetration of the needle is roughly of about 16 millimeters. So there are two approaches. One is the bicuspid approach, and this is in a straight plane, and this is easy to perform. The other approach is bisecting the two central incisor, that is the central incisor approach, but the target area is one and the same, that is the infraorbital foramen. So the advantages is it is a simple technique. It minimizes the volume of local anesthetic needed. The disadvantages are psychological to the administrator as well as to the patient because of fear of injury to the orbit. And some cases will feel the anatomical difficulty in defining the landmark. The complication is hematoma formation. So next we move on to the greater palatine nerve block. The nerve anesthetized is greater palatine nerve. Area anesthetized is posterior portion of the hard palate and is overlying soft tissues. Anteriorly as far as the first premolar and medially towards the mid-palatine raphe, that is towards the midline. The technique is you have to use a 27 gauge short needle. Area of insertion is soft tissue slightly anterior to the greater palatine foramen. The target area is greater palatine nerve as it passes anteriorly between the soft tissues and bone of the hard palate. Landmarks is greater palatine foramen and junction of the maxillary alveolar process and the mid-palatine raphe. So how to perform the procedure? The orientation of the needle is usually at a right angle. That is, the barrel of the syringe should approach from the opposite side. You have to palpate the greater palatine foramen. It is usually located on 1 centimeter on the distal aspect between the maxillary second and the maxillary third molar. So you have to start palpating the foramen anteriorly from the first premolar, then you can move downwards to feel the greater palatine foramen, and you have to deposit of about 0.45 to 0.5 ml of the solution. While injecting the solution, you will feel the ischemia or whitening or blanching of the mucosa. So when you appreciate that, that is indication of anesthesia of the greater palatine nerve. You can either use the cotton tip applicator to locate the foramen, or you can directly approach with the needle. Next is the nasopalatine nerve block. This is the last one of the anesthesia of the maxillary division. The nasopalatine nerve anesthesia effect is achieved by on these soft tissues of the from the canine till to the opposite side canine. That is the anterior portion of the hard palate, soft and hard tissues, bilaterally from the mesial aspect of the right first premolar to the mesial aspect of the left first premolar. So indications when palatal soft tissue anesthesia is necessary for restorative treatment on more than 2 teeth, and also for pain control during periodontal or oral surgical procedures involving the palatal soft tissues. So you'll be having a multiple approach, and or a single needle penetration approach. In the multiple approach, the first point of needle entry is at the label frenum, where you have to deposit 0.3 ml of the solution, and the second needle penetration is between the two central incisor in the interdental papilla. Perpendicular, the needle orientation is perpendicular, and the third needle insertion at the incisor foramen on the palatal aspect. So equally, you have to deposit 0.3 ml. Usually, for patients, they not prefer a multiple needle insertions. So to avoid this, we can go for a single needle penetration. And this is a clinical picture demonstrating the multiple approach of nasopalatine nerve block. One at the label frenum, the second needle insertion at the interdental papilla between the two central incisor, and third is at the incisor foramen on the palatal aspect. And this picture shows a single needle penetration for the block of nasopalatine nerve. So the needle orientation is at a 45-degree angle. So the orientation of the needle is at a 45-degree angle exactly at the incisor foramen. You have to deposit of about 0.45 ml, same as that of the greater palatine nerve block. So to summarize the techniques, the first technique is the posterior superior alveolar nerve block. The area anesthetized is the maxillary molar. Exceptional in some group of patients of about 28%, the mesobuccal root of the maxillary first molar is not anesthetized. So for that, you have to go for an additional local infiltration or supraperiosteal injection. And it also, you will get anesthesia effect on the hard and soft tissue on the buccal aspect. The solution required is 0.9 to 1.8 ml. And the most important complication of posterior superior alveolar nerve block is the hematoma formation. The second injection is the middle superior alveolar nerve. The middle superior alveolar nerve anesthesia, where you will achieve is, that is the first premolar, second premolar, as well, and also the mesobuccal root of the first molar. And the solution required is 0.9 to 1.2 ml. The third one is the anterior superior, which is also called as the infraorbital nerve block. Here you can appreciate this blue color from the maxillary central incisor till to the mesobuccal root of the first molar. So the solution deposited required is 0.9 to 1.2 ml. The greater palatine, again the palatal mucosa and hard palate from the first premolar till to the third molar. The solution required is 0.45 to 0.6 ml. Nasopalatine nerve block, hard and soft tissues of the palatal aspect of maxillary anterior teeth from distal of canine on one side to distal of canine on the contralateral side. Solution required is 0.45 ml. This completes the maxillary injection techniques. Thank you for watching my video. Thank you once again.